Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Tom, good to see you again.
Nice to see you, Parker, and I see your background still suggests you're on West Coast time. Is that correct?
That is correct. It is about 11:30 a.m. West Coast time. I was thinking about it. If you go back and you look at all of the different video episodes we've done, my background changes pretty frequently, and I guess I'm just working wherever the wind takes me.
It's nice because of the rise in telehealth and televideo that there is that flexibility, and especially being able to have colleagues who've picked up and gone to hang out in Hawaii and work for a bit, and I think it's something that everyone should take advantage of when possible.
Yeah, in my case, I'm in the sunny state of California, Southern California, which is a bit different from Virginia all the way on the East Coast where I'm generally based, but happy to be here on the podcast, making it happen. Brought my microphone with me. Totally ready to go.
Very good.
So welcome back to the Sit and Stay podcast. You are joined by your hosts Parker and Tom, as usual, of RipsyTech. Sorry, almost jumbled it there. So today, what are we talking about? Today we wanted to talk about office policies. They're something that every practice needs to have, that they need to communicate with their patients, get consent, and be enforced. And so there's so many different aspects to office policies that can go well and some that can maybe go wrong. So let's dive in. First up, we have just essential office policies. What are they? What are the ones that everybody should have? And how do these office policies impact the practice's daily operations and compliance with healthcare regulations?
Yeah, great question. And as you mentioned, Parker, every mental health clinic or doctor's office or optometrist or dentist, you need to have a list of office policies. And I'll, for the purposes of this podcast, we're going to assume that you're not above 50 employees. And we're also going to assume that you're, a mental health clinic and not a full-fledged medical office doing blood draws and dealing with infectious disease and hazardous waste and things like that. I will say in the clinics I previously ran, when we got over that 50 employee mark and then 100 employee mark, there were a lot of extra items that had to be squeezed into the office policies. And in addition, if we ever talk about an employee handbook, there are a lot of changes that happen there. And then there are the other little caveats that I think we won't include a ton in when we're discussing these general office policies are that if you do take Medicare or see Medicaid patients at your clinic, there are often blanket office policies or postings that you need in general to what you need to have for your clinic's basic office policies. And those tend to be different state by state, and something that you can go to the state website and get those and incorporate them. And also of note, and I'll just say it's not as much as an issue for mental health practices that accept insurance, but there can often be an extra slew of policies that say Anthem requires if you accept their insurance. Again, it tends to be more for primary care and other medical type clinics that a lot of those policies exist. There's a lot of things around evacuation, fire hazard things that just don't apply to smaller practices. So that's my legal disclaimer that we may not be covering everything that's actually required to go into your office policies. However, right. I would say you're very unlikely to get into any type of trouble if something is missing in your office policies. And for the purposes of this podcast, this is more, what do you need to communicate to your patients? That is, the basic pieces that are legally required. And then 2, what should be in there when there are problems with any piece of your office policies? Because in reality, it's back to this issue of you really don't need office policies or to review them for 98% of the patients you deal with. But then when you have that 1 or 2% that you do need to go back and show people what they signed, that's where you want to make sure you've done your due diligence at the start. And so I realize I've just said a lot of stuff without even talking about a single office policy, but I'll just see if you have any comments or questions about that before I.
Well, yeah, no, it just kind of reminds me of what I think we talked about last week when it came to having an office policy for billing reasons, making sure that I think we talked about how having sections for the patient to initial can be extremely useful if you then have a patient who is asking a question about a policy that's being enforced that they say, I didn't sign that, and then you can pull it up and you can show them the initial, like, well, actually, it's right here, so that kind of becomes very difficult for them to refute. So that just made me think of that, but. With all of that said, billing is one important policy. What about some others?
Yeah, and what I think I'll do is let's separate the financial policies for your clinic from the other sort of more general policies. And I'll say, the first thing that every clinic is required to specify, even if you're a private practice, is something related to HIPAA and protected health information. So since HIPAA became big, and I think it's ubiquitous now in society and healthcare, you need to have a statement regarding individual patient rights and protected health information, what the permission that patients have to give for sharing of protected health information, and what to do about when there's problems regarding anything with protected health information. There are lots of templates all over the internet for this. There's a little bit of required language that needs to go into the paragraph on patient rights. It has been reduced from when things first came out, and there was like 3 extra pages everyone had to put in. So by glancing at our current office policies, our HIPAA and protected health information is 2 paragraphs long at this time. And it has a mention about you can do a grievance with us or the Office of Civil Rights of Department of Health and Human Services about violations of rights, and you won't get in trouble for that. And some of those phrases are the required by law HIPAA ones. The second important piece of office policies is going to be that if you bill insurance, and this sort of relates to HIPAA and private protected health information, that there needs to be something in your office policy saying, all that being said about HIPAA, by coming to be seen at the clinic, you're giving us authorization to share that protected health information with your insurance company if we're going to be submitting for insurance reimbursement. So that ties in. You need to have that authorization. And I think even in RipsyTech, we require on the patient face sheet for all of our clinicians to check that they actually have gotten that authorization from their patients. So those ones out of the way, then when you're in your office policies, you're going to think about things that are going to be specific and important to how you do your mental health practice. So in no particular order, because of the rise of telehealth, and if you're using telehealth, putting something in your office policies about telehealth or video visits versus in-person visits is going to be important. In addition, in our field for mental health treatment, and especially working with kids, but also with adults, there's a rise in actually doing some sessions outside of your office, or if you're doing some exposure therapy for someone, or if it's a nice day, or I think there is actually nature therapy and hiking therapy. So if there's going to be any sort of off-site treatment, especially working with minors, I think it's important in your office policies that you put that you might take kids out for outside of the office, and make sure that parents know that they're signing up for that. I'd say also with some of these topics that I mentioned, it would be good diligence to, as we talked about last week, in assuming people really don't read them, that if you are going to be taking a minor patient outside of the office for whatever reason, you should also get verbal consent from the parent and put it in the medical record for that note.
Right.
Depending on what type of services you offer, like we like to put in a statement about therapeutic engagement. I think our group is mainly psychiatrists, and we want people to know that we're not a 15-minute medication mill type clinic.
Right.
So we actually put something in the office policies that we will do an assessment and recommend best practices, and we expect you to follow through on our recommendations for best practices. And if that's not something you're up for, then we're not the right clinic for you to be receiving treatment. We also put in a note about frequency of sessions that we require, and specifically for patients on medication, but even if you're just doing psychotherapy, having it established that there is a degree of engagement and time between visits that we expect. And then maybe just to not feel like I'm hogging the conversation, maybe after every few,
okay.
I'll pause and see if you have follow-up questions or comments, Parker.
Well, you mentioned all of the ones about HIPAA. What about the policies that pertain to when the provider might have to break HIPAA for any kind of safety reasons?
Oh, that's a good question. And I think those confidentiality practices are not necessarily something that need to go into your office policies.
Okay.
It is something that you need to talk about with each patient. And I know at our clinic, so this is more like a clinic policy, but not something that patients sign. Always at that first visit with patients who are adults or patients who are minors, speaking to the parents, is you let them know the confidentiality rules around if you're going to kill yourself or thinking about killing someone else, or for minors if they're being abused, that you always break confidentiality for that. I don't think it's wrong to put that in office policies, but I do feel like that one's so ingrained in our training to make sure you have this confidentiality discussion that it's good practice to always go over that. And interestingly, most teenagers and above that I see actually know these rules about it being reported, which is sort of interesting and positive, maybe with the rise of mental health awareness.
Yeah. Okay. So yeah, it's more of like based on the service that you're being provided. It's baked into the training of the provider. It's baked into the kind of the methodology of the type of service that you're requesting from this provider. So It might not necessarily be something that is written down in a policy, but it is something that is, it's legally required of that practitioner. So that makes a lot of sense. What about child-specific policies? You did mention some, specifically about like taking the child out on a walk or something, anything like that. What are some other policies that might be, child specific?
Yeah, no, really good comment. And we work with a lot of kids in our clinic. And so your policy, if you're treating minors, you're going to need to set a policy about, does a guardian need to be on site and on the premises at all times if you're treating a minor patient. And again, our current clinic is near a handful of coffee shops and nice places to sit outside. So we don't have anything in our office policies about requiring people to be on site for the time of their child's appointment. That being said, we do have a pick up your child on time clause in our office policies. It hasn't been too much of an issue since we're just doing outpatient services here. But if you're running groups or doing any intensive outpatient programs, it has come up many times in the past where sessions have ended and the clinic's closing and the parent's not there to pick up their kid. And of course, we recognize emergencies, but you should have, what's the late pickup fee going to be? And the sort of general clause around, repeated violation of any of the office policies could be result in discontinuation from services at the clinic. So those are very child specific policies that we currently have in our office policies.
Yeah, I did used to work in those intensive outpatient programs as a behavior specialist, and there was definitely nights where the program ended at 6, the clinic closed at 6, but we can't leave any child there if their parent's not there to pick them up. And I think the latest I ever had to stay was 7 o'clock, but luckily at that clinic we had a Wii, so we played Wii bowling for about an hour.
Very good. Yeah, no, good. And your comments there reminded me that the other, I don't think this is required for very small clinics, but I know at the larger clinic, we did actually require for teenagers who had their driver's license but weren't 18, are you going to allow them to drive themselves to their appointments and drive themselves home? And we don't currently have that in our office policies, but at the larger clinic previously ran, we did actually have a notice in the office policies and a separate consent form parents had to sign if they wanted to let their kids drive to and from their appointments. With the caveat that a parent has to be reachable by cell phone in case something happens.
Right.
The next couple of office policies are ones that you'll appreciate, Parker, and they're definitely not for all clinics, but if you're into research and improving treatment, now we just build into our office policies that we are going to be doing research on anonymized data to help improve the field. And if you don't want any of your data to be used, you need to let us know. And ethics boards have found that this language is acceptable to put in. And so we have that in our office policies. In all the years of having that, I think only one parent has ever opted out. Versus at the beginning, we used to sort of have a sign to opt in, which was many more people will just not sign something for multiple reasons. And then the other piece in the office policy we have is because we like to train other mental health professionals and can have people from all disciplines joining us, that we throw in a clause that we are a training institution and training clinic. So there may be trainees who join appropriately. This is another one of the, just because it's in the office policies, you're not going to pull trainees or students into private serious appointments. So you're going to use good judgment and get permission from the patient or the parent before you actually would bring a trainee in. But this is something you deal with a lot, especially going through medical school. The only way people will learn is by getting this training, and it is every patient's right to say, no, I don't want a trainee to be with me, but we really push back on this. It's like, how are people going to learn to be good practitioners if you don't allow that training? So for a lot of people out there, this one's probably more relevant than the research piece, because very often you could find yourself mentoring someone for a period of their training, even if you're in private practice.
Yeah, and then what if you are currently in training and trying to start your own practice? If I recall correctly, it's possible if you get a supervisor to do that, and then I suppose that would just be baked into that policy. Like, hey, I am a provider. I'm not currently licensed. I'm currently in training. It's going to be a $50 or just a $50 fee, or whatever amount they charge.
So there, to my understanding, there always has to be some sort of license. So it could be a provisional license, like an associate marriage and family therapist.
Yeah, that's what I meant.
Yeah, there are students, but usually students aren't allowed to open their own practice. They're working at a larger clinic. But it is true, you can be a psychological assistant on your way to being a psychologist. You can be an associate social worker, marriage and family therapist. You could be a licensed physician who is not fully done with training, but you're still available to see patients. And it is true that a lot of people with provisional licenses or associate licenses can open your own practice, but then you have different, I think in addition to office policies, you actually have to post information. I think there's different requirements by state and license level about what you're supposed to communicate to your patients if you don't have a full unrestricted license. Good question.
Gotcha.
Yeah.
Well, any other policies that would be good to cover before I
I think the last couple, the last few big ones that are non-financial policies would be, you should have something in about what's going to happen in case of an emergency, and for immediate safety concerns, and just putting that in your office policies. Something generally, I already mentioned this a little bit, but just about discontinuation of treatment and listing the reasons why you might discontinue treatment with a certain patient. And then maybe the most important one, and this one is the first one we talk about as that's not a financial policy, which is email and phone communication and or use of patient portal communication through your EHR. And this is one where you want to be very specific about what should be allowed in email, how long are phone calls going to be that are not during appointments, and do you send and receive text messages? What are policies around that, and time frame to respond to messages through patient portal? And this is this could probably be a whole episode on its own, Parker. And I think as you know, and as we're, our EHR currently has one-way messaging where a clinic can message information to patients, but we haven't implemented two-way messaging yet. And I think ultimately we will, but there are a lot of strong opinions about providers not wanting two-way messaging ability with their patients. I think we'll be putting it in with an option to turn it on or off.
Right.
And then the general piece is you don't want patients putting high emotional content, significant treatment questions, in emails, or having very long phone calls in between sessions. Just talking about the email piece first, we try to restrict it to general questions around scheduling follow-up, maybe a easy medication question, those that are straightforward and are very quick to answer. That's fine in email. I think every mental health clinician can tell stories of the 5-page emails they've received from patients or parents. And, then it's up to the clinic on how you're going to advise your staff or how you yourself are going to respond to those situations. We are very specific about quick phone calls are okay. But if it's something that's more than a quick phone call, we're going to make an appointment. One nice thing about the rise of telehealth is it does make it easier to turn a phone call into a telehealth appointment to answer questions, and it can generate extra revenue. But certainly there were providers who would be doing very long phone calls between sessions and not generating any reimbursement for that time well spent. And so you want to try to prevent that and make it clear in your office policies, the expectations around those communication.
What about OpenNotes? I know this is kind of a recent development in mental health care, but is it something that one would clarify in their policies?
That's a great question, Parker. And for people who don't know, the OpenNotes is that all patients now have access to all of their medical records, including mental health records. There is a caveat that you can indicate a note is highly confidential, and then you can put in the note content why you don't think the patient should see the note, and then you can hide it. It's not something that we've put in our office policies yet. It is, the law is that once there's easy access for the patients through an electronic health record to see their notes, whenever there is a new note, you need to not be sneaky about hiding that information.
Right.
I think that mental health records, we get concerned about. It's probably unnecessary concern. It's a controversial statement about people reading what you write. And I think knowing that if patients can see what you're writing about them in the note, it will encourage you to spend less time and be more general and maybe a little bit more efficient on some of the notes. But that being said, we don't have anything specific in our office policies about OpenNotes. I'm sure there are people that do put something in the office policies about the OpenNotes law.
Yeah, just something, I guess, it's not something that, in my experience, it's not something that a provider ever mentions. It's just kind of something that I have to know about. I've definitely had it where I did request once a couple years ago, and it took them a while, because I think when I had originally seen that provider, it was not a law, so they didn't know that they were going to have to eventually release this at some point. So yeah, it took them a while, and granted, I mean, I had my own kind of specific reason why I needed access to them, but yeah, it was definitely an interesting experience, and I almost kind of felt bad that I had to put them through that. But I mean,
yeah, Parker, that should be a whole separate podcast.
Yeah, sure.
Yeah, and especially in mental health, where we have this interactive complexity billing code that you can bill for when there's high tension or disagreement. So on one hand, we need to document some intense stuff to get some extra reimbursement, and then at the same time your patient can read that. I was actually on some of the initial phone calls because in child psychiatry, they did studies on VA patients reading their records and said, oh, okay, that hasn't caused any problems. And it's like, well, I don't think you can translate child psychiatry to like one study on some psych records from a VA hospital. There's a lot of sensitive material.
Right.
What do you do about ages 13 to 17? You don't want parents reading it. But anyway, yeah, it's like definitely its own podcast type topic.
Got it noted down. All right, so with all of those said, let's kind of pivot into, we're talking a lot about policies that might be really good for anybody to implement. What happens if policies need updating? What if a policy is not really working out? And I think there's kind of two different versions of this. There's you're a solo provider, or maybe it's a small handful of providers. Actually, let's go with there's a solo provider, but then maybe you're part of like as an alternate situation. Maybe you're part of a group of providers and you need to update a policy. What are the right ways to go about that process of creating a new, updated, effective policy?
Yeah, no, great question. And the reality is, like, probably 3 or 4 times a year, a clinic's office policies tend to get updated, or things have changed to the point where you should update them again. And this is especially relevant for the whole financial policy piece. But and I think the biggest thing that can change often are there changes in how you accept payment. It's usually issues around payment as opposed to the other things that we've previously talked about. And it's when a clinic is revising how it collects payments. Are you dropping an insurance? Are you going to be asking everyone for a credit card on file? And so it's like it is this question of when you're making a change as a solo practitioner, or if the group that you're a part of has decided to make any change to how the clinic is run, right? That's the sign that there's almost certainly an office policy that needs to be updated. It's a good exercise for groups or for individuals that want to change something to actually have to go back and reread, was there a current office policy on this, and how are we going to need to change it? And it will hopefully stimulate that additional talk among your colleagues, or just reflection if it's a private practice on how it should be worded. But we are in the process of updating our office policies, and in doing that, I realized there's some very outdated things in there that there's just no reason they're in there and are not relevant anymore. And it's part of just not being very thorough when we've been changing little pieces without reviewing other parts. So I think it's sort of general answers, but it was take your time, be thoughtful, review. Whenever you're just changing one thing, it's a good opportunity to review your whole office policies. And if a change you propose to office policies annoys 3 of your staff, that there's a conversation to have about that.
So then what do you do in the event that, the policy did get changed? How do you communicate that to the patients that you're seeing?
Yeah, so good question. And so the first piece is this like a very minor change where, you used to have a sentence saying, like before telehealth, maybe there was a sentence that, you need to bring a doctor's note if you're sick and don't show up. But then with telehealth, maybe it's like if you're under the weather, we still want to do a brief telehealth visit to avoid a cancellation fee. So certain policies may not be relevant to have to share, but anything that's going to have a significant impact, either cost-wise, again, it usually comes down to the financial policies. Is there a new no-show fee? Is there a new policy around late cancellations? Is there something around scheduling? Do you now only have 15 days to pay before a late fee is assessed? When you're doing significant changes like that, absolute best practice would be to have a live conversation, and at the end of the conversation, the patient signs or initials the new office policy. If you have a iPad set up or in a signature pad, that can tend to work well. You could still have a printed paper that they physically sign and you scan and upload. But anything significant should be a direct conversation with patients. which it's not necessarily pleasant to have to devote 5 or 10 minutes, and then sometimes that can be a 15-minute conversation about a policy change if a patient doesn't agree with it.
Right.
Yeah. So, but part of the price of doing business.
So, what about the staff? Let's go with like front desk staff, for example. Maybe they're the ones who are, up front there to reinforce a lot of these policies or get the signatures for a lot of these policies. How do you, effectively communicate with them to make sure that they're aware of the new policies, and, how do you prevent any possible issues there?
Yeah, no, good question. And this, when we had lots of front desk staff, right, their primary job is the patient interaction. And so they're really the most important people to be on top of the policies, know what the actual policies are, and not rely on that patients are going to read and understand everything that they're signing.
Right.
So it is that what we would do if you have office staff is for those important changes, they're going to be the ones communicating it to the patients and getting that electronic or physical signature on the updated office policies. And they're just going to be the experts and know the office policies better than the rest of the staff. If there's an office policy change that results in tension, you don't want to put that whole burden on office staff. So if you're large enough to have a supervisor, that's fine. But otherwise, if it's a handful of providers and one office staff, if things get out of hand, the office staff person should immediately pitch it to that patient's clinician to talk about with them and explain they're not the one making the policies. So let me direct you to your clinician who can explain it in more detail. And then Parker, real quick on the financial policies. I don't know if I specifically listed what those were that you should have, and these are kind of our first page policies now.
Oh yeah, let's dive into that.
So number one is just something about cancellations. How many hours is your cancellation policy, and what's the cost? Do you give one free cancellation a year? Do you allow, say, if you get rescheduled in the same week, it's waived? But whatever you do about cancellations, have that in there. A line about payment. When are payments expected? Is it monthly? Is it right after the visit? That needs to be in there. You need to have a conversation about something in there about if you're requiring a credit card on file or linked with a payment processor. That information needs to be there for people to refer to. And then the final one that it's the result of another of the No Surprises Act is you need to be very direct about the maximum cost people will be paying for your services. Now, this doesn't actually have to be listed in the office policies. And so what we do is just in bold, it's your responsibility to go to our website, here's the link, and read the maximum costs for your treatment. And then on the website, we have our costs laid out, which again, we've talked about, a lot of clinics don't do that. And then the other piece that we're being more bold about now is, requiring patients to actually reach out to their insurance companies to verify their own benefits. So even though we do this ourselves, and Ripsy will do this, it is not always correct. But more importantly, we've just been getting frustrations with patients not being aware of their insurance plans or high deductibles or mental health carve-outs. So as an extra step now, we're putting a requirement on patients to initial that they have actually reached out to their insurance company and they've also seen the maximum cost and that they have awareness of how much it's going to be seen at our clinic. So those are our financial policies.
Yeah, that's really interesting on that last one. I haven't had a provider do that for me, but I will say I think everybody should be familiar with their benefits for their insurance. It's just good practice for anytime you get a new health insurance policy to just make sure you are make sure you're equipping yourself to be as aware as possible about, what's going to be covered, what's not. A lot of the times there are, I'll speak for myself. There are times where I probably should have gone to my insurance company first before seeking services from a specific provider, just to find out, if I had gone through the specific recommended path by my insurance company, I might have saved myself a lot of money rather than going straight to the provider. So I do think that is really good practice for really anybody who, especially when they're getting a new insurance policy.
Yeah. And I'll say the one other very important piece of office policies, that's not specifically a financial policy, but that we put on our sort of first in-your-face office policy page is, you're not. We do a 3 or 4 session assessment for each patient, and we make it clear that you are not our patient until after the assessment, and we both agreed that you're a good fit for our clinic. So if you're going to have, there are rules around once you take a patient into your clinic and start that treatment relationship. And so we want to be very mindful that, hey, we're going to do an assessment. If we're a good fit in both directions, that's when you become a patient, and that clinician-patient relationship begins. But that does not happen on your first visit with us. So we emphasize that in our office policies. And that's the final important one I wanted to get out there.
Yeah, great. Well said. So when it comes to actually enforcing these policies, what might be some common pitfalls that we can expect might happen, or, well, hopefully hope not to happen, in respect to both, enforcement of the policy on the patient side, maybe the front desk side, the provider side even? Go ahead.
Yeah, no, and I think, like I said at the beginning, it's very rare you ever need to pull out the office policies and show people what they've signed. I think a bigger concern can come up when you set office policies, and then, like you mentioned, maybe front desk, or maybe some of the clinicians or providers, if you work in a group, are not aware of the office policy, or they don't follow their end of the bargain. For example, the comments I made about communication via email or phone, every place I've worked, there's been the long emails, and then there's been the clinician who should have wrote back, "Thanks for sending this. We'll talk about it at your next appointment," or "Thanks for sending this. Please schedule so we can discuss." Often people will get into a very long response back to the patient, and then that lets the patient, that gives positive reinforcement. Hey, I wrote this long email and I actually got clinician information back, and that was handy for me. And as soon as you have staff that aren't following the office policies, it can create problems, for enforcing them, or create confusion at the least when, if patients do wind up getting very long phone calls or very long email responses, then that's an example of a situation where the office policies fail. I think the most, usually you're going to pull out the office policies when a credit card was declined, or something didn't happen with payment, or there's a big fight about a cancellation fee. That's the majority of the times where you pull out your office policies and show what patients have signed. And if things ever get to the point of collections or small claims court, that's where the initials and that document is going to give you the victory. Again, hopefully you never get to that point of having to do something like that, but that it is the payment, late fees, cancellation charges that are when you usually need to pull out the office policies.
Right. So we've talked a lot about a bunch of different types of policies, both office policies, financial policies. I'm wondering if you have any examples of any specific times where a specific policy was implemented that had a significant improvement for both the practice or for the patient?
Yeah, I think actually even the policy about we're going to do an assessment first and agree to treatment, that we didn't always have that policy, and that was sort of something that I learned several years into the practice. And I think the best piece about that office policy and about training the rest of the clinicians about that policy is it gets a very nice conversation going with your patients about mental health treatment in general. And our style here, and I think the correct style for mental health practitioners, is you're a team working with a patient or family to make someone's mental health better. The idea that someone's coming in and you're doing some magic, secret magic behind a closed door in psychotherapy, doesn't serve anyone. It puts extra pressure on mental health clinicians to do that magic. And it's much better to say, hey, I've had this training, but I'm human too. Let's be a team and work together, and I'll bring insights. And especially for kids, you're not going to achieve anything without parents being part of the team. So as soon as we made the office policy about we're going to do this assessment and see if it's a good fit, it forced a lot of the clinicians to have better conversations around what a care contract is, expectations on both sides, and that definitely improved the relationship and all the way through to people getting better and practice outcomes. I think we've tried lots of things around practice management, and even now we're going with electronic signatures of office policies. Well, that's maybe a little bit more convenient to actually get them signed than back in the days where you're chasing after people with clipboards. Now you can send a text before they start and people sign the office policies, but I don't know if that's helped or hurt practice management with having the non-paper signature of office policies. And I think, there are definitely things you can do in the office that can improve the practice management. I don't know how much you can do with what you've written in the office policies to actually improve practice management. So that's the sync between what's most important to you in the practice of your office. That's going to be the key pieces to your practice management, how you word that in your office policies and convey that. We struggle with that right now with everything with electronic signatures and people reading what they're signing. So sorry, that's a little cynical, but
no, it's all good. Any other final thoughts before we move on?
Yeah, no, I think the simpler the better. And if you, as we know from giving presentations, Parker, it's better to have 4 bullet points on a slide in big font than lots of small text. So
yeah, absolutely.
Probably the most effective office policy would be a front and back page of large font bullet points. Certain requirements around HIPAA and authorization release preclude that, but I'd like to see a little revolution in consent forms, but I don't think the lawyers will let that happen.
Well, I'm not particularly. This is my UX hat that I'm wearing right now. My user experience hat that I'm wearing. I'm not a huge fan of large text. I actually don't think a lot of people read large text. I think bolding specific sections. Don't bold all of it, but bold specific sections that are like, if you're going to take away any words from skimming through this, make sure that these are the words that you're registering. Some strategic bolding. That's kind of how I like to approach it.
I will go with the UX designer's advice. Yeah.
Well, with that said, let's dive into a mental health business moment for the week. What are we looking at this week? Anything? I'm on the edge of my seat.
Yeah, and I'm realizing our goal of keeping the podcast more like 20, 25 minutes. I've really not made that happen this week, so I apologize for that.
We're approaching about 48, I think, but that's okay. It's a big topic.
Yeah, I'm actually stealing something that happened to our esteemed guest, Dr. Steve Kachi, for the mental health business moment of the week, which I've, in all my years of helping people and running practices, I've not seen. But yeah, Dr. Kachi was negotiating with an insurance company and received a set the initial rates, and then wrote back and explained why he deserved better rates. And in response to that, they sent back rates that were literally half of the initial rates and said, we just changed how we do reimbursement. Here's your rates.
My goodness.
And I've never seen the negotiation go backwards. And then to just further show the ridiculousness of the situation, they said, of course you could still accept those initial rates if you wanted to.
That's nice.
So, anyway, it's that's a new one.
Yeah, that is an odd situation for sure.
Yeah.
Well, very interesting. Okay, well, I mean, this was as you said, a little bit of a longer episode, but I think really kind of dove into the weeds, specifically on different types of policies that exist, and I think we maybe spent half the episode on that in particular, which I think we got a lot of great information here. So let's go ahead and wrap up. As always, if anybody would like to send us questions, you can send those to sitandstay@RipsyTech.com. And if anybody is interested in being a guest, like we had last week with Dr. Kachi, reach out, and we'll, if the fit is right, never know what might happen.
Very good. Thanks, Parker.
All right. See you next week, Tom.
See you soon.
Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.